Hello, everyone. Thank you for joining us today, and I'd like to thank the organizers for the opportunity to speak. So cancer risk reduction has often relied on the patient to do the right thing, perhaps having a good healthcare provider to guide them in doing the right thing, maintaining a healthy lifestyle, exercising, avoiding certain bad habits and lifestyles, maybe taking an aspirin for chemoprevention. But the focus also is on the participation in screening programs. Let's say colonoscopy for the prevention of colon cancer, where a precursor lesion could be identified and removed before cancer developed. Or taking up mammography for the early detection of breast cancer should it develop. Doing what we can to stay ahead of cancer or detecting cancer early in order to have the best outcomes. But we all know that patients develop cancer even if they've done everything right. And their outcomes may not be always so favorable. We know that the cancer biology can remain elusive, but we still have the patients that present, the new mother, the 30-year-old with breast cancer, or you heard about the young actor in his 40s with advanced colon cancer who wasn't even eligible for colorectal cancer screening. How about the patient that presents with their third or fourth cancer, or families where it seems that everybody had cancer? Who are these patients? Why so young? Why so many cancers? Why such a heavy burden of cancer in families? These patients are the patients we see at the Cancer Center in our high-risk and prevention clinics. They present to not only ask the why, but also how. How are we going to improve their survivorship? And it affords us the opportunity to provide collaborative, multidisciplinary care to those individuals, to offer them really novel and strategic approaches to how to optimize their survival. We take the opportunity to look at genetics in their tumors, but also to assess for inherited susceptibility, and whether there's a faulty gene, a pathogenic variant that might explain their cancers, because that too can impact their treatment and outcomes. Importantly, that information also trickles down to family members, those individuals, many of whom don't have cancer, but are considered now at higher risk and are motivated to take measures to prevent cancer. So the role and application of genetic testing has come a long way, but its application and rather its implementation at populations at large still needs some work. I want to just make a point that when I refer to genetic testing, I'm referring to germline genetic testing. So when a pathogenic variant exists, a faulty gene that is passed on from one generation to the next. Many of you probably know BRCA and hereditary breast and ovarian cancer, a very well-recognized inherited cancer syndrome. Angelina Jolie publicized it many years ago. The uptake of germline genetic testing skyrocketed after she announced and shared her journey with her mother's case of ovarian cancer and being identified as a BRCA1 carrier. She's an example of a previvor, an individual known to carry an increased risk of cancer due to a pathogenic variant in a cancer susceptibility gene. A previvor has the ability to use that information to take on cancer risk-reducing efforts, whether it's intensive screening and surveillance or risk-reducing surgeries, to participate in trials related to chemoprevention. So where were we 50 years ago with respect to genetic risk assessment? We actually did have a biomarker 50 years ago. It was free. It actually really required a physician's time and curiosity. It's the family history. And this is very simple, a very simple slide that really shows an experience that a family can have. And this is really powerful because the patients who present with a family history, some of them who present unaffected, are really motivated to do more, are motivated and engaged to know what's out there, to do the right thing. So 50 years ago, we would look at a family like this. Someone would present often with a young onset of cancer, and we would see that the family was riddled with multiple malignancies. And for the next 25 years, we developed family cancer registries and built biorepositories. And over time, we were able to define clinical criteria that defined families by cancer types and cancer spectrums. We were also able, based on this simple family tree, to develop screening guidelines to advise patients how they needed to then prevent additional cancers, or in family members who weren't unaffected by cancer, what they needed to do to reduce their risk. And 25 or so years later, in the mid-1990s, gene discoveries were made. BRCA was discovered, and cancer risk in certain families like this was better defined. And that information really trickles down also to individuals and family members and to our previvors who have a great opportunity to reduce their risk of cancer. So I want to use an example of an inherited cancer syndrome near and dear to my heart, Lynch syndrome. I'm a gastroenterologist, and Lynch syndrome is the most common inherited colon cancer syndrome. Lynch syndrome is associated with a 10 to 60% increased risk of colorectal cancer. The general population average risk for developing colon cancer is 6%. Someone who's at average risk for colon cancer probably needs somewhere like 3 colonoscopies in their lifetime for the ability and the possibility of preventing colon cancer. A patient with Lynch syndrome starts screening at age 25 and undergoes intensive surveillance with colonoscopy every 1 to 2 years. That's about 30 to 50 colonoscopies in their lifetime. These patients are ideal to consider novel strategies of cancer screening, liquid biopsies, and are actually a wonderful cohort to explore the performance of some of these new tools and technologies in high risk. Lynch syndrome also causes a number of extracolonic cancers. Women are at increased risk for endometrial cancer and ovarian cancer. When they're done with childbearing, often before they hit menopause, the recommendation is to undergo total abdominal hysterectomy and bilateral oophorectomy. So to prevent cancer in these patients takes a large commitment. Now I want to go back and really talk to you about the history of Lynch syndrome because we've made great advances. Lynch syndrome was described close to 100 years ago, actually a little over 100 years ago, by Dr. Warthen. He was a pathologist at the University of Michigan. He had time and was curious. He had nothing to do with cancer pathology at the time. He was curious because his seamstress would come in distraught every so often. Multiple family members, multiple siblings were affected with cancer, different types of cancers across multiple generations, many succumbing to cancer at a young age. And Dr. Warthen first described her family, known as Family G, which would be followed for many years later. This is the original pedigree by Dr. Warthen. In 1960, Henry Lynch continued to follow Family G. He also accumulated many other families in which multiple cancers presented. Colon cancer, hereditary colon cancer, and Lynch syndrome is named after Henry Lynch, shown here. He was bold in the 1960s to make a claim that cancer could be inherited. Having met Henry Lynch and having heard him speak, he said he was looked at as a quack at that time. Nobody thought that cancer could be inherited. It was all environmental. But he persisted, and his families later on were used to make groundbreaking discoveries in Lynch syndrome and the mismatch repair genes that are associated with Lynch syndrome. So family history defined Lynch syndrome in the 60s and later on. It was not until the 80s when we had a new biomarker for Lynch syndrome, and that was the tumor. Colon cancer tumors have a special feature and a hallmark feature, and that's microsatellite instability. About 95% of all Lynch syndrome cancers exhibit microsatellite instability because Lynch syndrome is caused by mismatch repair deficiency. So microsatellite instability is pretty important these days because of immunotherapy. In fact, many cancers now are screened for microsatellite instability, not to identify Lynch syndrome, but to target treatment and for the use of immunotherapy. With that, we've been really discovering more and more cases of Lynch syndrome, kind of through the back door. The tumors of these cancers show microsatellite instability, and all thereafter go on to germline testing, where we have the opportunity to identify this high-risk condition. So Lynch syndrome is not uncommon. 1 in 300 individuals has Lynch syndrome. That's the same prevalence as BRCA-associated hereditary breast and ovarian cancer. However, the difference is that a lot of individuals with Lynch syndrome don't know they have it. In fact, it's estimated that over 1 million Americans have Lynch syndrome, but just don't know it. So our focus now, and the opportunity that we have, is to move away from the cancer patient and to actually focus on the previvors, to focus on the family members, those who are at risk based on knowing the pathogenic variant in their relative with cancer. So how could we do this? A simple way is to go back to the family tree, the simple pedigree. And if you identify, shown here, the cancer patient, the female with cancer tested and found to carry a pathogenic variant, the implications of that finding are great, because all these relatives have a risk. These at-risk relatives are then eligible for genetic testing. Predictive genetic testing can inform them as to whether or not they carry the disease, and then afterwards to improve any risk-reducing strategies. I just want to point out that the impact is tremendous when you identify one mutation carrier. It trickles down to other generations. And of course, every pedigree has a face to it. Our lovely patient here has Lynch syndrome. She has 5 children shown in the back with their spouses. Genetic testing can identify who benefits from screening and also can classify those who don't have Lynch and can then go on to general population recommendations of screening. And then we have a younger generation who could also benefit from that information. I wish I could say that this kind of approach, where we take our proband with the germline mutation and extend genetic testing, could yield 100% identification for these conditions. This approach of cascade testing to capture every relative doesn't work so well. At best, we can capture near 40% of family members who are at risk. So we have to get creative. A lot of our research has focused on creating risk assessment tools based on family history that provide calculated risk scores, tools that can be incorporated into the electronic medical record, where family history can be plugged in to get a risk score of when a patient should undergo genetic testing. But we have to think beyond that as well. And one approach that we may be seeing, and I don't think we'll need to wait 50 years, is to actually consider predictive genetic testing in the general population, in health. So to consider having a 25-year-old or 30-year-old who comes in for a well visit, where they're screened for hypertension, hypercholesterolemia, diabetes, and possibly inherited cancer susceptibility. I don't think we're that far off. In fact, the Office of Public Health Genomics of the CDC has classified 3 conditions as Tier 1 conditions for which population-based genetic testing is appropriate. 2 of those 3 conditions are related to inherited cancer. 1 is Lynch syndrome, 2 is BRCA, the 3rd is familial hypercholesterolemia. So I think we will be seeing in the near future the discussions of when to consider germline testing in the general population. I think one added benefit, and a very important benefit, of providing population-based germline testing is that it will provide equitable care. Social determinants and inherent biases have held back many advancements for underrepresented populations. Clinical cancer genetics is no different. And I actually think it might have a bigger gap because the technology has moved so fast where our clinical interpretation of data has not only lagged, but is unclear in underrepresented populations who haven't participated in research, who have barely undergone enough genetic testing to know what results mean. To give you an example, the uptake of genetic testing in a US commercial laboratory, if you look at the demographics of who undergoes testing, 85% of individuals self-report as white from European backgrounds. In that 85% group, it's a near split of patients with cancer and those without. So the message has resonated for certain populations that genetic testing can be used in health without cancer, and to use that information to guide screening strategies, to guide preventive risk-reducing strategies. The 15% who do not identify as white, of European descent, the majority of those individuals have cancer. The majority of those individuals have early onset cancer. So the approach to those patients is the approach we've had many, many years ago. What that points out is that very few individuals who are Black, Asian, Latino are getting genetic testing in health based on the family history, based on their knowledge and know-how that important information could help guide their screening and prevention. So I want to finish up with something that I find tremendously exciting. A trial is opening up for Lynch syndrome Previvors. It will be recruiting patients for a vaccine trial. Lynch syndrome is a unique condition in that its mutations are predictable and they yield a distinct set of neoantigens that can be targeted. So this trial is opening up for Previvors with the hopes of a real tool of immunoprevention. So it feels like we've come full circle in Lynch syndrome, in taking care and optimizing the care of patients with immunotherapy, but also with the potential of using immunopreventive approaches and vaccines. I don't think we'll need to wait 50 years, and I'm excited for that. So in conclusion, we're here at Columbia to optimize the care of all our cancer patients, and with the hopes of keeping our Previvors cancer-free. Thank you.